A very good evening to all of you, and I welcome you all to this particular YouTube session. So in this session, we will be discussing the image-based questions in the general medicine. And yes, so I hope everyone is completely geared up for the exam which is going to be conducted on the 4th of December, right? And I wish everyone all the best. And these 2 or 3 days are very important days for your revision. Yes, Sai Tarni, good evening. So these 2 or 3 days are very, very important days for your revision. So in this 2 or 3 days, please don't get depressed or don't get completely stressed out. These 2 or 3 days are very important for you for your final revision, final wrap up revision. Okay, so that is the reason why please be completely with a hope that you will definitely clear the exam. Either don't be underconfident or don't be overconfident as well. Okay, right. Yes, Shahid Afridi, good evening. Yes, Bhargavi, good evening. All right, now let us start with the session. The patient has presented with weight loss. What is the most likely diagnosis? You observe the neck of the individual, observe the clavicles, observe the supraclavicular area, and then give the answer. Gastric cancer, lung cancer, melanoma, nasopharyngeal cancer, thyroid cancer. The patient had presented with weight loss. What is the most likely diagnosis? Right. So, very good, Santosh. Excellent. So, the answer here is the gastric cancer. Why? See, I have rounded off one important structure. So, what is this important structure? This is nothing but your swelling of left supraclavicular lymph node. Right? Swelling of left supraclavicular lymph node. Now, can anyone tell me what is this particular lymph node called? The answer is the gastric cancer. The answer is the gastric cancer. Okay. Now, this left supraclavicular lymph node, right? This left supraclavicular lymph node is nothing but your virtuous lymph node, right? Or this is also called the trochleus lymph node, right? This is also called the trochleus lymph node. So where do you have this particular virtuous lymph node or the trochleus lymph node is? That is in patients with the gastric cancer, right? That is in patients with the gastric cancer, there will be metastasis, right? There will be metastasis from stomach to left supraclavicular lymph node. Right, from stomach to the left supraclavicular lymph node. Okay, so this is nothing but your virtuous lymph node or the trochleus lymph node. So the one which you have to observe in this image is this area. This is the swollen lymph node, right? Yeah, so that is seen in case of the carcinoma of the stomach. Now we will move on to the next question. Right, so you see this image. This 23-year-old man involved in a motor vehicle accident. What is the diagnosis? Aortic dissection, cardiac rupture, diaphragmatic rupture, pneumothorax, vertebral fractures. Right, so I have slightly enlarged the image as well. Yes, this 23-year-old man was involved in a motor vehicle accident. What is the diagnosis? So, right, what is given for you? The chest X-ray is given to you. You observe the X-ray properly and then let me know what exactly is the diagnosis. Very good. So Bhargavi has answered it. Very good, Bhargavi. So the answer is the pneumothorax. Now, why are you saying this pneumothorax? You see this. This is what is your deep lucent sign. Right? This is called deep lucent sign. This deep lucent sign, right? This deep lucent sign, it is the sign of, right? You see this? This is the sign of pneumothorax. Right? This is a sign of pneumothorax. Okay. So you are having that, yeah, very good Indian football. So that costophrenic angle, it is completely deep. So this is what is called as the deep lucent sign, or it is also called as the deep sulcus sign, which is very much suggestive of the pneumothorax. Now, what about in aortic dissection? In aortic dissection, the chest X-ray shows widening of the mediastinum. You don't have that in this image. Right? You have the presence of the widening of the mediastinum in case of the aortic dissection. And yeah, and yes, now the only differential diagnosis what we need to discuss is about the aortic dissection, because that is one of the differential what you can have after a motor vehicle accident. But in case of the aortic dissection, you will have the widening of the mediastinum. Okay, right. And if you take the vertebral fracture, and you can see all the vertebra, they're absolutely normal. They don't have any particular the hairline fracture or any complete fracture as well. So even your vertebral fracture is ruled out. So what is the answer to this question now? That is your pneumothorax. Okay. So this is nothing but your deep lucent sign. Right? Deep lucent right costophrenic angle on the supine chest radiograph. That is an indirect sign of the pneumothorax. Right? That is an indirect sign of the pneumothorax. Okay. Now we will move on to the next question. Right. So this is another very interesting question. Yeah. What is the diagnosis? Bancroftian filariasis, deep vein thrombosis, erythema, lipodermatosclerosis, superficial thrombophlebitis. Superficial thrombophlebitis. What is the diagnosis in this image? Can anyone answer? Right. So what is that you have to make out in this particular images? You have a hyperpigmented, very good, very good. Sai Taruni has answered it. It is your superficial thrombophlebitis. Right? So this is your superficial thrombophlebitis. Now, how will you make out that it is a superficial thrombophlebitis? In case of superficial thrombophlebitis, you have the presence of the erythema, right? And that particular erythematous hyperpigment area, it is a tender which is present on the medial aspect of the left knee, right? Which is present on the medial aspect of the left knee. So the same thing is given in the image as well. So it is an erythematous structure which is present on the medial aspect of the left knee. This is very much suggestive of your superficial thrombophlebitis. Right? You have to suspect superficial thrombophlebitis. Okay. Right. Now we will move on to the next image. Yes. So these oral ulcers were painless. What is the most likely diagnosis? what is the most likely diagnosis? Any one of you? No. It is not herpes. See, in case of the herpes infection, like what is that you will have? You will have the presence of the vesicles or the pustular lesions. Very good. So Gangula Akanksha has answered it. Very good, Gangula Akanksha. So it is your syphilis. It is your syphilis. Among the options given to you, right? Herpes simplex, it is not painless. It is painful. Right? It is extremely painful in case of the herpes simplex. Okay. And it is in case of the syphilis, you will have the presence of the painless oral ulcers. Right? You will have the presence of the painless oral ulcers. Okay. Right. So the ulcer, it is clean, smooth bases, slightly elevated, and indurated borders. So the presence of this painless ulcer, this is typical of syphilitic chancre. Right? Syphilitic chancre. Okay. Right. Whereas, and many of you were answering it as the chancroid. Right? Many of you were answering it as the chancroid. Let me tell you, even your chancroid, this is painful. Right? Chancroid is also a very painful lesion. So chancroid is not the answer, and herpes simplex is also not the answer. Okay. So where is that you will have the painless lesion? That is only in the syphilis. Okay. Right. Now, let me just move on to the next image. Yes. So this is one of the very interesting question, and let me see how many of you can crack this. Yeah. What is the most likely diagnosis in this clinical scenario? Acromegaly, cystic fibrosis, Eisenmenger syndrome, squamous cell carcinoma of the lung, ulcerative colitis. So what is there? You please tell me what are the findings you are observing? Yes, very good, Selvaraju. Selvaraju, can you tell me what is the findings you are seeing in the image? The answer is Eisenmenger syndrome. The answer is Eisenmenger syndrome. Selvaraju, can you tell me what is the finding you are seeing? Yes, Gangula Akanksha, you are correct. So the findings, what you are observing there, it is your differential clubbing. Now you should, it is not clubbed fingers in both upper limbs and lower limbs. It is your differential clubbing. So differential clubbing in the sense, right? So differential clubbing in the sense, you have the clubbing only in the lower limbs, right? You see here, only in the lower limbs, you have the presence of clubbing. Whereas the upper limbs, the digits of the upper limbs, they are absolutely normal. Right? The digits of the upper limb, they are absolutely normal. They don't have clubbing. So this is called as the differential clubbing. And where do you have this particular differential clubbing? You will have this in patients with Eisenmenger syndrome with PDA. Right? You will have this in patients with Eisenmenger syndrome with PDA, patent ductus arteriosus. Now, can anyone tell me what is this Eisenmenger syndrome? Yes? What is this Eisenmenger syndrome? Any one of you? So, Eisenmenger syndrome is, right. So, Eisenmenger syndrome is reversal of the shunt. The shunt will be from right to left. Right? The shunt will be from right to left. Very good, Vinod Selvaraju. Now, in which type of shunt of right to left, you will have the differential clubbing. That is in case of the PDA. So in case of PDA with Eisenmengers, the upper limbs will be absolutely normal, whereas in lower limbs, you will have the presence of the clubbing. Or there can be even cyanosis as well. So this is what is called as the differential clubbing. This is what is called as differential clubbing. All right. Now we will move on to the next question. Right. So this is another very interesting question, and let me see how many of you can crack this. What is the diagnosis? Right. An abdominal X-ray is being given to you. Gastric outlet obstruction, Hirschsprung disease, ileal intussusception, ulcerative colitis, Zollinger-Ellison syndrome. Anyone? Zollinger-Ellison syndrome. No. Not Zollinger-Ellison syndrome. Pooja Selvan. Gastric outlet obstruction. See, where do you have this dilatation? What is the structure which is being completely dilated? What is the structure which is being completely dilated? Where is that particular gaseous shadow you are able to make out? What is that structure, first of all? Any one of you? So, the dilated structure, right? The dilated structure, whichever is shown to you in the abdominal X-ray, is your transverse colon. Now, based on this, you please tell me what will be the answer, right? The structure which has been abnormally dilated, it is your transverse colon. It is not stomach. It is not stomach. Okay. Now, in which one of the clinical scenarios the abdominal X-ray shows severely dilated transverse colon? That is in case of the ulcerative colitis, right? That is in case of the ulcerative colitis. Okay. So the answer in this question, right, it is the ulcerative colitis. So I did not get the correct answer only from one student, that is Santosh, right? Very good, Santosh. Only Santosh has answered it, right? So the answer is the ulcerative colitis. Okay, right. Now we will move on to the next question. Yes, this is another very interesting question. Observe the image properly, right? Observe the image properly. 23-year-old man presented with a 1-month history of severe pubic itch, right? A very severe pubic itch that was worst at the night, right? That was worst at the night. What is the appropriate topical treatment you will give to the patient? Hydrocortisone, hydroxyzine, mupirocin, permethrin, selenium sulfate. So you closely observe. Very good, very good. Sai Taruni has answered it. Yes. So the answer is permethrin. The answer is permethrin. So whatever you're seeing here, can anyone describe the image? So what is that you are seeing in the image along with the hair? So in the image, what has been shown to you is the presence of pediculosis, right? The presence of the pubic pediculosis. Now, to this particular pubic pediculosis, right, you need to give permethrin, right? You need to give permethrin, okay? So the answer to this particular question here is permethrin. So this is your pubic pediculosis, right? Okay, so these are your pubic pediculosis. Okay, now we will move on to the next question. Okay, now this is another a challenge, right? Really an interesting question. What diagnosis explains the loss of visual acuity in this woman who is at 36 weeks of gestation? Right? What diagnosis explains the loss of visual acuity in this woman who is at 36 weeks of gestation? Central serous chorioretinitis, diabetes mellitus, glaucoma, Graves' disease, the preeclampsia. So observe that fundus properly and then answer. And some of you should be able to tell me, right, what is that you are seeing within the fundus? Central serous chorioretinitis answered by Gangula Akanksha. Okay, any other answer? Diabetes mellitus answered by Indian football and Shahid Afridi. Glaucoma answered by Vinod Selvakumar, Selvaraju. Right. See, I just described the image for you. Okay. So these are your cotton wool spots. Okay. So we got one correct answer, that is from Sazidur Rahman. Right. Only one correct answer from Sazidur Rahman. So these are all your cotton wool spots. Right. These are all your cotton wool spots. Okay. Now, cotton wool spots, where do you have? In case of hypertension. Now, in which particular clinical scenario of the options given to you, you will have the hypertension that is in patients with the preeclampsia, right? That is in patients with the preeclampsia. So in case of the preeclampsia, right, you will have the presence of the hypertension. So the answer to this particular question is the preeclampsia, right? Why? Because you are able to see the presence of the cotton wool spots, right? And you are also able to make out the presence of the hemorrhages and swelling of the optic disc, right? And the swelling of the optic disc, right? So this is your optic disc where you can make out that it has been completely swollen. And here, these are your hemorrhages. Right? These are your hemorrhages. Okay, right. So this is a clear case of the hypertensive retinopathy, right? And which grade? It is grade 4 hypertensive retinopathy. And I'll show you one more fundus image, right? So this is another fundus image. Yeah, this patient presented with transient, painless, right? Painless visual obscuration in the left eye. What is the diagnosis? Papilledema, hypertensive retinopathy, cholesterol emboli, temporal arteritis, diabetic retinopathy, right? So I'll just slightly enlarge the image as well. So what were the options? Papilledema, hypertensive retinopathy, and third option is cholesterol emboli. Fourth option is temporal arteritis. Fifth option is diabetic retinopathy. Right. So you observe the image properly. You observe the image properly. Very good. So Santosh again has answered. Very good, Santosh. So the answer to this particular question is the presence of the cholesterol emboli. Sir, where are the cholesterol emboli? Right? I'll just round it off. This is the cholesterol emboli. Right? This is your cholesterol emboli. The yellow colored dots, yellow colored dots, whatever you are seeing within the retinal vasculature, these are your cholesterol emboli. Right? These are all your cholesterol emboli. Okay? You see here, right? So this is your cholesterol emboli. Okay, right. So the answer is 3. Now, many of you were answering it as diabetic retinopathy. Now, can anyone tell me what will be the fundus examination in diabetic retinopathy? Any one of you? What will be the fundus examination image in diabetic retinopathy? Right, yeah. See, the image is slightly small for you, but I hope in your exam you will get a proper image. But one or two, this one, yes, Rayman, this one you are able to see. These you are able to see. Right, very good, Gangula Akanksha. So in case of diabetic retinopathy, like what you will have is the microaneurysms and as well as neovascularization. Right, neovascularization. So you don't have the neovascularization here. What is this image suggestive of? This image suggestive of the cholesterol emboli. Right, so this is one of the very interesting image. You should not miss this image in your exam at all. Now you see the next question. Yes, so and let me see who will answer this. You observe the lesions properly. You observe the lesions properly. What is the diagnosis? Aphthous stomatitis, bullous pemphigoid, chickenpox, herpes zoster, paraneoplastic pemphigus. You see the description of that particular lesions, right? So they are like vesicle and they are following a classical dermatomal distribution. You see this? This is your classical dermatomal distribution, right? In a specific dermatome, you have that particular vesicular lesions. So now tell me, what is the diagnosis? Very good, Pooja Selvam. So the answer here is the herpes zoster. Okay, the answer here is herpes zoster. So the description of the lesions in the herpes zoster will be vesicles will be there, and these vesicles will be in an appropriate dermatomal distribution. Right, will be in appropriate dermatomal distribution. So that is what is your lesions of the herpes zoster. That is what is your lesions of the herpes zoster. Okay, right. Now, after having discussed about the lesions of the herpes zoster, now let me take up the next image. Yeah, so this is very interesting. What is the most likely underlying diagnosis? Cirrhosis of liver, chronic renal failure, hypothyroidism, myeloma, sickle cell disease. Yes, any one of you? What is the most likely underlying diagnosis? Very good. So very good, Santosh and Bhargavi. So what is this? This is your spider angioma. right? This is your spider angioma. So this particular spider angioma, it is classically seen in case of cirrhosis of liver, right? This is classically seen in case of the cirrhosis of liver, okay, right? And this particular spider angiomas, they're mainly because of increase in the estrogen in the cirrhosis of liver, right? They are mainly because of increase in the estrogen level within the cirrhosis of liver, okay, right? So the answer to this particular question is the spider angioma. All right, now we will move on to the next question. Yes, this is another very interesting question, and let me see how many of you can crack this. This 12-year-old presented with decreased appetite and as well as the vomiting, right? What is the most likely diagnosis? Right? What is the most likely diagnosis? Endometrioma, hernia, keloid, intraabdominal cancer, urachal duct cyst. So the history is also very important in this. What is the history telling you? Decreased appetite and as well as vomiting. So can anyone tell me what is this image which has been given to you? Right. So the answer here is intra-abdominal cancer. Why, sir? Why intra-abdominal cancer? What is being given to you? What is being given to you is Sister Mary Joseph's nodule. Right? What has been given to you there is Sister Mary Joseph's nodule. Right? Which is the lymphatic metastasis to the umbilical region. Right? Which is nothing but your lymphatic metastasis to the umbilical region. So what is this lymphatic metastasis from? The lymphatic metastasis, it is from large pelvic mass, right? It is from large pelvic mass. And this particular large pelvic mass can be from metastasizing from the ovary. And this large pelvic mass can be metastasizing from the liver. Okay. So whatever is being shown to you is lymphatic metastasis to the umbilicus. That is Sister Mary Joseph's nodule. Right? So what is this? It is the lymphatic metastasis from the intra-abdominal cancer. Right? Lymphatic metastasis from the intra-abdominal cancer. Okay. So the answer to your question is 4. Sir, how can we tell? Why not the hernia? Why not like keloid? See, the description is very clear. That is decreased appetite. So where will you have this particular decreased appetite? Mainly in case of the individual with an underlying malignancy. So this is a catch, right? So this is a catch of this particular question, right? Now we will move on to the next immediate question. Okay, so this you should be able to, okay, which clinical presentation would be expected in this patient, right? So this is this is an image which has which has shown to you from a patient which I have seen personally. So this patient also presented with a pinpointed pupil as well, right? This patient also presented with a pinpointed pupil. That was the presentation, right? Pinpointed pupil. And I have examined all the 4 limbs, and I have also examined the eyes of these individuals. And now tell me what clinical presentation would be expected in this patient? Hemiparesis. Okay. So yes, Sai Taruni, can you tell me in which clinical scenario you will have this pinpointed pupil? In which clinical scenario you will have the pinpointed pupil? Very good. So Vinod Selvaraju has answered this. Right. Quadriplegia. See, now, Sai Taruni, I do definitely accept that is in case of organophosphorus poisoning. But in organophosphorus poisoning, do you have any particular hemorrhagic lesions within the brain? This is a hemorrhage. Whatever the CT image is showing to you is an hemorrhage. Right? Sir, how are you telling it's an hemorrhage? It's a hyperdense lesion. Right? It's a hyperdense lesion. So now a pinpointed pupil with hyperdense lesion within the brain, what is that? That is your pontine hemorrhage, right? Very good, Santosh and Chaitanya. So this is nothing but your pontine hemorrhage, okay? So in case of pontine hemorrhage, you will have the presence of the pinpointed pupil, right? You will have the presence of the pinpointed pupil, and they will also have the quadriplegia. The presentation of these patients will be in the form of quadriplegia, right? So the most common presentation of a pontine hemorrhage is quadriplegia. Okay, right. And the other point why to tell quadriplegia is, in this individual, the hemorrhage, it is bilaterally symmetrical, right? The hemorrhage, it is bilaterally symmetrical. Okay, right. Yes, Shahid Afridi, you will be definitely having multiple differential diagnosis to this, but I have given you a very important clue. The very important clue is your pinpointed pupil. Okay, so where will you have your pinpointed pupil? Definitely in case of the pontine hemorrhage. So that hyperdense lesion suggests you of your pontine hemorrhage with bilaterally symmetrical will have a clinical finding of quadriplegia. Yes, you see this neck swelling. What is the most likely diagnosis in this patient who underwent fine needle aspiration after reporting several weeks of submandibular pain? See, this word is history is very important. Several weeks of submandibular pain. Several weeks of submandibular pain. Adenoid cystic carcinoma, cat scratch disease, infectious mononucleosis, sclerosing sialadenitis, systemic lupus erythematosus. Right. So we have got the correct answer from Santosh. So that is sclerosing sialadenitis. Now, what is this sclerosing sialadenitis? Right. The word itself tells you adenitis, inflammation of the salivary glands. Sialadenitis, it's an inflammation of salivary glands. Sclerosing, so it's an inflammatory fibrosing lesion, right? Inflammatory fibrosing condition of the salivary glands. Right? Inflammatory fibrosing condition of the salivary glands. And this inflammatory fibrosing condition of the salivary glands, right? They're usually bilateral. They're usually bilateral. Okay. Whereas you take the other options, like you take carcinoma. Carcinomas usually they'll not be bilateral. Carcinomas, they're usually asymmetrical. Right? They are usually asymmetrical. Okay. So the presence of several weeks of submandibular pain and that too a bilateral lesion, that is what is suggestive of the sclerosing sialadenitis. Okay. Right. Now we will move on to the next image. Yes. what is the most likely diagnosis in this asymptomatic 17-year-old male, right? Antroconal polyp, foreign body, palatine tonsil or palatine tonsillitis, pharyngeal lymphoma, tonsillar abscess, right? So I have slightly enlarged the image also, so you can see this, right? So this is the image. You see this, how is that particular structure, right? Very good, Vinod Selvaraju. So Vinod Selvaraju and Pooja Selvam has answered it correctly. The answer is the antroconal polyp. The answer is the antroconal polyp. So now you take, some of you are answering it as pharyngeal lymphoma. See, in case of lymphoma, the individual will not be asymptomatic. In case of the pharyngeal lymphomas, the individual will have the weight loss, there can be decreased appetite, and they can also present to you with the dysphagia, where in case of your pharyngeal lymphoma. But the dysphagia is not there, decreased appetite is not there, weight loss is not there. So that is the reason why the tumor, that is pharyngeal lymphoma, can be ruled out. So that polypoid structure, where exactly is present in the nasopharyngeal area, right? That is exactly at the junction of the soft palate and as well as the pharynx, right? It is not even at the soft palate, behind the soft palate. So that is exactly the antroconal polyp, right? So this is your polyp, right? This is your polyp. Okay. Now we will move on to the next question. Right. So this is one of the very interesting question also. And let me see how many of you can crack this. What is the diagnosis? Angioedema, cardiac tamponade, necrotizing fasciitis, superior vena cava syndrome, toxic epidermal necrolysis. Very good, Santosh. So the answer here is the superior vena cava syndrome. The answer here, whatever is given, is your superior vena cava syndrome, right? Now, why the answer is being the superior vena cava syndrome? Now, you see the upper half of the body, it is completely red or erythematous. Or cyanosed, right? Or cyanosed. Now, where do you have the upper half of the body being erythematous and as well as cyanosed, and lower half of the body, right? This is absolutely normal, right? Lower half of the body is absolutely normal. And you have that particular cyanosis or erythema mainly within the SVC drainage, that is superior vena cava drainage. So in case of the SVC drainage, right, if the venous blood is not being drained, if the venous blood is not being drained, then the upper half of the body will be cyanosed. What is the area drained by the superior vena cava? The face, neck, both the upper limbs, and as well as the upper part of the chest. So these are all the areas drained by the venous drainage is into the superior vena cava, right? It is into the superior vena cava. Now, because the superior vena cava is blocked in this clinical scenario, that is the reason why the upper half of the body is being appeared as cyanosed or erythematous. Okay, right. Now we will move on to the next question. Yes. So this is another very interesting question, right? What is the most likely diagnosis in this asymptomatic? This word is very important. Asymptomatic male Dercum's disease, familial multiple lipomatosis, Madelung's disease, neurofibromatosis type 1, rheumatoid arthritis, right? So I will also slightly enlarge the image as well. Yes. Santosh, you have answered it as the Dercum's disease. But let me tell you, Dercum's disease, they do present with this multiple swellings. But in Dercum's, they are painless, they are painful swelling. Right? You will have the painful swelling in the Dercum's disease. Right? So what is the answer here then? The answer in this question is familial multiple lipomatosis. Right? So you can see here, these are like your multiple swellings, both in the upper limb and as well as in the lower limbs. Right? Both in the upper limb and as well as lower limbs, you can make out that there is presence of multiple swellings. So this is your familial multiple lipomatosis. Right? Familial multiple lipomatosis. Okay, and these familial multiple lipomatosis, these are the painless lesions, or these are your painless swelling. Right? These are your painless swelling. Okay, so that is about your familial multiple lipomatosis. Right? And definitely I do understand Dercum's disease is one of the very important differential diagnosis. But Dercum's disease, that is a painful swelling. It is not painless swelling. Right? So that is how you will be able to differentiate Dercum's disease from familial multiple lipomatosis. Right? Next. Yeah. So this is another very interesting question. Yes. You observe the tongue properly. Right? Observe the tongue properly. What is the most likely diagnosis? Ankylosing, atrophic glossitis, Creutzfeldt-Jakob disease, hypoglossal nerve palsy, motor neuron disease. Very good. So Vinod Selvaraju, you have answered it correctly. The answer is the hypoglossal nerve injury. Right? Let me slightly enlarge the image now. Yes, you see this? This part of the tongue, right? This part of the tongue is completely wasted. Right? This part of the tongue, it is being completely wasted. So you can see, and the other thing is, the tongue is deviated towards the affected side. Right? So on whichever side the tongue is paralyzed, the tongue is deviated towards the side of paralysis. Right? The tongue is deviated towards the side of the paralysis. Okay? Towards the same side of the paralysis. Okay? Now, how can you tell that it is the hypoglossal nerve injury? Why? Because it is in case of the hypoglossal nerve, which is the motor supplied to the tongue. Right? It is your hypoglossal nerve, which is the motor supplied to the tongue. So once your hypoglossal nerve is damaged, the muscles within the tongue, right? The muscles within the tongue, they are completely paralyzed. Muscles within the tongue will be completely paralyzed. Okay, right? So the correct answer is said by many of you, right? Very good. Now you see the next question. So if you see the next question, yes. So this is another interesting question. and you have many differential diagnoses also, but you should be able to diagnose this. What is the most likely diagnosis? You see this question properly. Most likely diagnosis in this patient who had suffered a blunt head trauma 2 months earlier, right? What is the most likely diagnosis in this patient who had suffered a blunt head trauma 2 months earlier? Acute angle closure glaucoma, carotid cavernous fistula, ocular lymphoma, periorbital cellulitis, thyroid ophthalmopathy. Very good. So I got a correct answer from Santosh. Very good, Santosh. So what are the findings? Number one, yes. So number one, the individual is having proptosis. Number two, the individual is having the corneal ulceration. Right? And the individual is also having the chemosis. Right? The chemosis. Okay. So proptosis, chemosis, that is, chemosis is what? The edema of the conjunctiva. Conjunctival edema is nothing but your chemosis. So proptosis, chemosis, and as well as the corneal ulceration. That is what will give you a diagnosis of the carotid cavernous fistula. Now, in case of acute angle closure glaucoma, what is that you will have? You will have a very painful eye. Right? You will have a very painful eye. And in case of the periorbital cellulitis, only in the periorbital area, you will have the presence of the swelling in the periorbital cellulitis. You don't have this particular chemosis and as well as corneal ulceration in case of the periorbital cellulitis. And in case of thyroid ophthalmopathy, you will have the presence of only proptosis. That is nothing but your Graves' ophthalmopathy. Right? That is nothing but your Graves' ophthalmopathy. Okay. Right. We will move on to the next last question. Right. So this is a very, very interesting image. Right. Very interesting image. Yes. What is the most likely diagnosis in this patient? Achalasia cardia, diffuse esophageal spasm, esophageal stricture, hiatal hernia, systemic sclerosis. Very good, Devaraj. So the answer is the diffuse esophageal spasm. So what is that you're observing here? You are seeing the presence of corkscrew appearance of the esophagus. Right? You are having corkscrew appearance of the esophagus. Okay. So where will you have this corkscrew appearance of the esophagus? You will have that in case of the diffuse esophageal spasm. Right? You will have that in patients with the diffuse esophageal spasm. Okay. So these are some of the important image-based questions for today. Right? So I'll come up live again tomorrow, wherein I will discuss some more image-based questions just before your exam. And the tomorrow's questions will be a very, very important questions. Please do attend that session live, where I will discuss how to approach to your difficult questions in your upcoming FMG exam that is on December 4th. So until that, today night and tomorrow morning and the entire day of tomorrow is very, very important for you for revision. Don't read any new things, and if anything being discussed live which is completely new, images, right, please do solve them. We don't know like what question will appear in your exam, what image will appear in your exam. So please do attend this particular image based session tomorrow as well. That will be the last session. So I'll take up for 2 hours tomorrow, where I will discuss nearly around 100 images tomorrow. Okay, so thank you very much, and be confident, stay safe, and stay hopeful. Don't get depressed.